Good morning. Welcome to the NHSN Surgical Site Infection Surveillance in 2018. It's great to have all of you here today. I'm Jennifer Watkins, and I am the newest member of the NHSN SSI team, which also includes Victoria Russo and Denise Sleep-Trott. The SSI presentation is kind of a long one because we have a lot of material to cover. I'll be presenting for an hour, then we'll take a 15-minute break, and then Vicki will present the remainder of the information. After that, we'll take some questions, and we'll spend about the last 30 minutes or so working on an interactive case presentation. During the presentation, we'll have some knowledge checks for you, so you use your clickers to answer those questions. Our objectives today are as follows. We're going to identify some SSI 2018 updates. We're going to describe SSI key terms and definitions. We're going to work on learning how to complete the SSI event form and the SSI denominator for procedure form. We're going to understand how to link an SSI event to a procedure record. And we're going to apply NHSN SSI criteria to case scenarios. So our goal today is really to get everybody to the same basic knowledge level required to conduct SSI surveillance. And as we're going through the presentation, those of you here in the GCC will want to refer to your resource manual where we've included SSI definitions that are necessary to answer the questions. And also on the web stream, you want to refer to Chapter 9 and 17 to help you answer these case questions. So why do we do SSI surveillance? Each year, there are an estimated 157,000 surgical site infections in the US with an associated 8,205 deaths. And 11% of ICU deaths are associated with an SSI. SSIs are one of the most common healthcare-associated infections. Not only is there significant morbidity and mortality associated with SSIs, there are also increased costs for the healthcare system, including increased patient days and increased readmissions. These statistics highlight why it is so important for us to conduct SSI surveillance, implement SSI prevention measures, and to measure the effects of these interventions. So as you know, it's important to keep up with the NHSN annual updates so you be sure that you're applying the most current NHSN surveillance definitions. So in the next few slides, I'm going to cover some of the SSI-related updates for 2018. At the bottom of every NHSN webpage, there are icons that link to the newsletters and the email updates that are sent out to NHSN users. So if you click on the email updates icon, it will take you to this page. And as you can see, the highlighted link is linked to the updates that were sent out to everybody in December for the 2018 patient safety component. So a few of the SSI updates for 2018 include, we've updated the date of event to add additional guidance surrounding tissue level and time frame for elements. We've also updated the trauma definition to cover some cases requiring multiple trips to the OR. And we've clarified the invasive manipulation accession SSI event reporting instruction. This list is not all-encompassing. They're just some of the highlighted SSI updates. And we'll be covering these more in depth later in the presentation. Additionally, the 2018 NHSN Operative Procedure Codes have been updated. There are two separate documents on the SSI webpage, one for the ICD-10 PCS codes and one for the CPT codes. And I'll show you how to find them later. Just want to remind you to continue using the 2017 code list for all procedures that were done through December 31st of 2017, and then use the 2018 code list for any procedures performed on or after January 1st, 2018. So Kathy covered these updates yesterday, but since GIT and IAB are frequently used in SSI surveillance, I just want to highlight them again. GIT has been updated to allow blood as an element in Criterion 1. The retroperitoneal space has been moved to IAB from UCI. Hypotension and elevated transaminase levels have been added as symptoms for IAB Criterion 3. And the IAB reporting instruction has been revised to include biliary ductal dilatation as an equivocal imaging finding for cholangitis. And last update, which Kathy also covered yesterday, NHSN has assumed the checklist for the NHSN HAI definitions from the Tennessee Department of Health, and we're hoping that you use these tools and find them helpful for SSI case determinations. Now I'm going to take you on a brief navigation through the NHSN SSI event web pages. From the side navigation bar, the SSI landing page is found by going to the NHSN main page, materials for enrolled facilities, acute care hospitals, and then down here to the surveillance for SSI events. As you can see, we've got several resources listed on the web page. The first drop-down, protocols, the training drop-down provides links to SSI trainings available from NHSN, including the annual webinars. Right now, we still have the 2017 webinars up there, but we'll be updating those with the 2018 webinars for you. The next drop-down is the most important. This is where you'll find the 2018 NHSN SSI protocol. Next, we have the frequently asked questions, or FAQs. This includes links to the SSI FAQs and some other FAQ documents that are useful for SSI surveillance. And the FAQs have a new look this year. You can just click on any of the questions in the menu. It'll take you straight down the page to the question and the answer that you're looking for. And I encourage you to utilize the FAQ documents because they have a lot of useful information that may supplement what's in the protocols. Next, we have the data collection forms. Here you can find data collection forms and their tables of instructions, or TOIs. This is where you'll find the SSI event form and the denominator procedure form. And remember, that's one of our objectives today, is to learn how to fill these out. The most important thing to remember about this section is that when you're filling out the forms, utilize the table of instructions. There's a lot of really useful information that will help you understand how to fill out those data fields and give you definitions on what's needed to accurately obtain that data. The next section is a CMS supporting materials section. It contains up-to-date information, requirements, instructions, and deadlines for the CMS IQR program, which Jim covered. So these are just some supplemental documents on our website that will direct you to some of the answers you may have about CMS reporting. The supporting materials section is another really important section. This is where you're going to find the ICD-10 PCS and CPT code documents for both 2017 and 2018. You're also going to find your guidance for reporting K-Pro and H-Pro procedures and some of the other guidance that you need for filling out denominator procedures. Also in this section, we have some more 2018 protocols. The locations protocol, the key terms protocol, and Chapter 17 are links to that are here. And there's also a link to the 2018 NHSN organisms list. So how do you communicate to NHSN what procedures you're following? The monthly reporting plan is the roadmap to your data. It's where you tell NHSN what HAIs or facility is following every month and what data we should expect you to be entering into the application. Only your in-plan data, as indicated on your monthly reporting plan, will be included in CDC aggregate data analysis. And as a reminder, when you decide to follow a procedure in your reporting plan, you are agreeing that you're going to follow the surveillance protocol in its entirety. For an SSI, that means that all SSIs, superficial, deep, and organ space, should be reported into the NHS application, even though deep and organ space are only sent to CMS. Likewise, you also should report SSI events that are KTOS equals yes. That's part of the surveillance protocol. Even though those aren't reported to CMS either, they still need to be put into NHSN. So when you're doing SSI surveillance, what data does NHSN expect you to enter related to these procedures? We use the SSI event and the denominator procedure forms to indicate which data you need to enter. On the top, you'll see the surgical site infection event form, and this is where you collect your SSI event data or numerator data. And the bottom form is the denominator procedure form, and this is where you'll collect your denominator procedure data. Remember to refer to your TOIs or tables of instructions if you have questions about what elements are required for each data field. Remember, if your facility uses vendor data, but provides systems to upload this data, be sure to review the data before it's uploaded into NHSN for data accuracy. Next, I want to touch on the concept of active surveillance methods for SSIs. There are different ways to perform SSI surveillance within your facility, including reviewing medical records or surgery clinic patient records, looking at admission, readmission, ED, and OR logs, reviewing patient charts for signs and symptoms of SSIs, looking at your labs, x-rays, and diagnostic tests or reports, reviewing nurses' and physicians' notes, and visiting your ICUs and wards and talking to the primary care staff. They have a lot of valuable information that can help you with your surveillance. I really want to encourage you to participate in multidisciplinary rounds as a way to discuss the status of the patients with the staff in real time. And remember, you can meet some of the SSI definitions without a wound culture, so don't rely on wound cultures as your primary method of surveillance. So remember that the SSI surveillance period does not end on patient discharge, so I want to talk about some of the post-discharge surveillance methods you can use. Some facilities will use surgeon or patient surveys by mail or phone and contact them to see if SSIs have been reported or if patients have signs and symptoms or sought health care post-discharge for SSIs. You can also, some facilities have access to their post-operative clinic records, so that's a really good resource for you if you're looking for post-op discharge SSI information. Some facilities also review their line lists of readmissions and ED admissions for diagnoses and symptoms that might be related to an SSI. And also, some facilities will run line lists of targeted diagnostic codes, such as infection codes, to identify patients with a potential SSI that are being readmitted to their facility. These line lists are a form of enhanced surveillance that will really give you a heads up as to whether or not you have an SSI. I also want to note how important it is to have good communication with other hospitals or facilities in your area. So if one of your patients is admitted or treated by another facility, that they'll be able to identify you of a potential SSI that you can investigate. So now let's cover some key terms and definitions for SSI surveillance. The NHSN patient safety component is comprised of 4 modules, and the SSI protocol is located in the procedure associated module, and it has its own definitions for classifying infections. As Kathy covered yesterday, the definitions in the table do not apply to SSI surveillance. POA, HAI, and RIT do not apply to SSI, as each visit to the OR starts either a 30 or 90-day surveillance period for an SSI. SSI also doesn't use the terms date of event and secondary BSI attribution period as defined by Kathy yesterday. We have our own definitions for those events, or those terms in the SSI protocol. So the first definition we're going to cover is an NHSN operative procedure. The definition of an NHSN operative procedure has not changed from 2017 to 2018. So the definition is an NHSN operative procedure is a procedure that is included in the ICD-10 PCS or CPT NHSN operative procedure code mapping. So remember, when you're doing SSI surveillance, to check your ICD-10 and CPT codes associated with the OR procedures performed in your facility to see if the procedure maps as an NHSN operative procedure category. Procedures that do not map as such NHSN operative procedures are not included in SSI surveillance. An NHSN operative procedure is also a procedure that takes place during an operation where at least one incision is made through the skin or mucous membrane or via reoperation via an incision that was left open during a prior operative procedure. And it takes place in an operating room as defined by the FGI or AIA guidelines. Two other key definitions for SSI surveillance are NHSN inpatient operative procedure and NHSN outpatient operative procedure. An NHSN inpatient operative procedure is a procedure that was performed on a patient whose date of admission to the healthcare facility and the date of discharge are different calendar days. So if your patient has an overnight stay, that's an inpatient operative procedure. An NHSN outpatient operative procedure is an operative procedure performed on a patient whose date of admission to the healthcare facility and date of discharge are the same day. The only change we made for 2018 is we removed some guidance about specific locations in the outpatient operative procedure definition. We just simplified it for you. When you're identifying procedures for SSI surveillance, make sure that whatever your method you're using is capturing all your inpatient procedures. The patient's billing status may not agree with the NHSN definition. So for example, if you have a patient who's being billed for an outpatient hysterectomy, but they spend the night in an inpatient location, that meets the definition of an inpatient operative procedure for NHSN reporting purposes. So make sure that whatever method you're using to find your procedures is capturing all those inpatient procedures accurately. The next key term is date of event, and we did update this definition for 2018. So for an SSI, the date of event is the date when the first element used to meet SSI for infection criterion occurs for the first time during the surveillance period. The date of event must fall within the surveillance period. If the date of event falls outside the surveillance period, you won't meet SSI criteria. Since there's no IWP in SSI surveillance, we're often asked about the time frame for symptoms. And this information we've added to the date of event definition. It's also can be found in an FAQ. So all of the symptoms required to meet SSI criteria usually occur within a 7 to 10-day time frame, and they usually have no more than 2 to 3 days between the elements. We want to make sure these elements are relational to each other, meaning that they occur relatively closely together, and we can determine that they're related to the SSI. So if you had a temperature on day 3 post-op, and then you have a positive blood culture on day 14, probably not relational due to that extended time frame. But if the temperature and the blood culture occur within 2 to 3 days of each other, probably relational. But remember, each case differs based on the individual elements that are occurring and the type of SSI you're evaluating. And if you're not sure, you can always email us and we'll try to help guide you. And remember, if your depth of SSI progresses during the surveillance time period, you're going to want to update the event to the deeper SSI level with a new date of event. And your new date of event should be the date when the first element used to meet the deeper SSI infection criterion occurred for the first time during the surveillance period. So for example, if you have a colo procedure, and then on day 6 is your date of event for meeting an SSI, superficial SSI, and then on day 25, your date of event is the date of event for meeting an organ space IAB SSI. You're going to want to report the IAB SSI on day 25. You never want to report 2 SSIs of the same site to the same operative procedure during the surveillance period. You're just going to report that deepest level of SSI. And if the SSI meets a deeper level outside of the surveillance period, you're not going to upgrade. So if that patient met with a date of event of an organ space IAB SSI on day 31 post-op, you won't report that. They've already ended the surveillance period, so that superficial is the only one you report. The next key term is aseptic technique. Aseptic technique refers to specimens obtained in a manner to prevent introduction of organisms from the surrounding tissues into the specimen being collected. Remember, aseptic technique refers to how the specimen was collected, not where the specimen was collected. So as long as they're collecting the specimen properly, it is considered aseptic. And while there are general guidelines for the collection of optimum wound specimens, specific procedures for specimen collection and transport are institution dependent. And IP should review these practices with their colleagues to assure that aseptic technique is being used to obtain the wound cultures. If you have wound culture results with mixed flora or mixed cutaneous flora alone, that cannot be reported to NHSN. However, if you receive a positive wound culture that has an organism identified in addition to the mixed cutaneous flora, then you can use that pathogen. So for example, if you have a wound culture that results with Staph aureus and mixed flora, that Staph aureus is an identified pathogen that can be used to meet criteria. And if you're getting a lot of wound cultures with results with mixed flora or mixed cutaneous flora, you might want to work with your colleagues to make sure that they are actually collecting the wound specimens using aseptic technique and the protocols for your institution. Pathogen assignment. So there are very few organisms that are excluded from being used to meet SSI criteria. You can see a list of the genera there, and I'm not going to say them all because I'll probably stumble over half of them. And the last one is organisms associated with latent infections. Those are things like tuberculosis, shingles, things like that. Syphilis is another one. If you have multiple wound cultures from the same site, so if you have, for example, an SSI site is cultured and you have Staph aureus, and then that same site is cultured again at the same level or a deeper level, and you identify a second pathogen, such as E. coli, you would just add that E. coli onto the SSI event form. And another thing we're often asked about is if an organism is identified from broth only, can you be used to meet SSI criteria? And the answer is yes. Broth is a culture media that can be enriched to identify organisms that might otherwise be missed on other growth media. So these are eligible organisms to meet SSI criteria. And I also want to mention that common commensal organisms are not excluded from meeting SSI criteria. And here's our first case, so please use your clickers to submit your answers. 4 days following his colo procedure, prior to discharge, a 35-year-old male developed redness and serous drainage from his superficial incision site. A culture of the drainage from the superficial incision was obtained at the bedside, and Staphylococcus epidermidis was isolated. Can this culture be used to meet SSI criteria? And, okay, polling is open, so I'll give you a few seconds to submit your answers. Okay, I'm going to close the poll. And the correct, most of you got that right. The correct answer is yes. So the rationale. There's a misconception by some people that only cultures obtained in the OR are aseptic, but remember, aseptic technique refers to how the culture is collected, not where it's collected. And also, as we covered, there's only very few excluded organisms, and the common commensal organisms are not excluded from meeting SSI criteria. So this is an acceptable specimen. Next, we're going to talk about secondary BSI scenarios. This is another concept where SSI has its own definition for secondary BSIs. There are two scenarios related to secondary BSI attribution for SSI. In scenario one, at least one organism from the blood specimen matches an organism identified from the site-specific infection that is used as an element to meet NHSN site-specific infection criterion. So, for example, if you have a deep incisional infection with a Staph aureus identified, and you have a secondary blood culture with Staph aureus identified in the secondary BSI attribution period, that will be a secondary BSI to your deep incisional SSI. Scenario two is when you have an organism identified from the blood specimen, and that organism or that blood specimen is an element used to meet the NHSN site-specific infection criterion. So, for example, if you're applying IAB criteria, there is a criterion where you can use blood as an element. So, if you have that blood culture, you can meet the IAB definition, and that would be a secondary BSI to your SSI. You cannot apply scenario 2 to superficial and deep incisional SSIs, because remember, that's not, blood is not an element of the superficial or deep SSIs. So you do have to have a matching pathogen for a secondary BSI to a superficial or deep incisional SSI. Sorry. And if you remember from the date of event definition, we train that all the elements used to meet the criteria must occur within the same general time frame. So the IWP does not apply when you're applying scenario 2 to secondary BSIs. So we give you a little more leeway. It does not have to fall within that 7-day IWP if you have a blood culture that you're trying to use as secondary to an SSI. This is just an illustration of the SSI secondary BSI attribution period. Other HAIs use the IWP and the RIT tied to determine their secondary SSI secondary BSI attribution period. But since we don't have those definitions here in SSI protocol, the SSI secondary BSI attribution period is defined as the date of event, the 3 days before the date of event, and the 13 days after event for a 17-day SSI secondary BSI attribution period. And as Kathy mentioned yesterday, the reason we have those 3 days before the date of event is because sometimes you see a blood culture collected and then they go on to do further testing to determine the primary site of attribution. The other thing I want to mention is the 13 days following the date of event can fall outside the 30-day surveillance period for your SSI. So for example, if you have a date of event on day 29 of a 30-day surveillance period, your secondary BSI can occur outside of that 30-day surveillance period, so keep that in mind. As you recall, present on admission or POA definition doesn't apply in SSI surveillance. If there is evidence of infection present before or at the time of surgery and the patient meets SSI criteria during the surveillance period, the SSI is attributed to the procedure. So instead of POA, the SSI protocol uses infection present at the time of surgery, or PATOS. And PATOS denotes that there is evidence of an infection or abscess at the start of or during the index surgical procedure. In other words, it's present preoperatively. The patient does not have to meet the NHSN definition of an SSI at the time of the primary procedure to meet PATOS criteria, but in order to meet PATOS criteria, there must be documentation of evidence of infection, such as an abscess, purulence, or pus in the intraoperative note. Identification of an organism by cultural or non-cultural based microbiological testing doesn't meet this criteria, and a pathology report from a surgical specimen also doesn't meet PATOS. Sometimes you'll see verbiage of colon perforation or necrosis or gangrene or fecal spillage, Nick bowel, or inflammation noted in the operative note. These also don't meet PATOS because these terms are more synonymous with contamination, but not infection. And we have more details about what can and cannot meet PATOS in our SSI event protocol and in the FAQs. I also want to note that this field is a required field on the SSI event form. So it's not on the denominator form. You assess for PATOS only after you identify that the patient has an SSI. So you're only going to select PATOS yes if it applies to the depth of the SSI that is being attributed to the procedure. So for example, if the patient had evidence of an intra-abdominal infection at the time of surgery and later returns with an organ-space SSI, the PATOS field would be selected as yes. But if the patient returned with a superficial or deep incisional SSI, the PATOS field would be selected as no, because it's not at the same depth. And as I mentioned earlier, PATOS is a data field on the numerator field that's required. It's not on the denominator procedure form. And PATOS is only considered if an SSI is determined within the surveillance period following that operative procedure. I just want to remind you that colon hist SSI events with PATOS equals yes and their corresponding procedures are not sent to CMS, and they're not included in the complex 30-day SSI SAR, but these SSI events are still required to be reported to NHSN as part of the protocol. And the reason we do this is because we want these events to be available to you to analyze within your own facility and to be able to monitor any of your quality improvement practices related to these events. We also have a 6-minute quick learn video about PATOS that you can find under the training section on the NHSN SSI landing page. I highly recommend this. It's only 6 minutes of time, and it's got a little really valuable information. So I suggest you take a look at that if you have more questions about PATOS. So here's an example of PATOS equals yes. On February 1st, your patient presents to the ED with an acute abdomen and goes directly to the OR for colon resection. A peritoneal abscess is documented intraoperatively and drained through an abdominal washout, and a thorough abdominal washout is performed. The incision is loosely covered with some packing between staples, and a JP drain is placed in an adjacent stab wound. On February 4th, the patient is discharged with their wounds healing well. Then on February 8th, the patient presents to the ED with fever, abdominal pain, and an abdominal CT is performed. The abdominal CT identifies a left lower quadrant abscess with a subsequent CT-guided drainage of the abscess, which identifies positive for E. coli. This is reported as an SSI IAB. It meets IAB criterion 1. And then when you're entering your SSI event form, the PATOS field will be entered as yes. And why is this? On 2.8, pardon? First, you got to assess the fact that you have an SSI. So on 2.8, your patient meets SSI IAB criteria. So once you've determined that patient meets their SSI, then you would go back to the intraoperative note to see if the doctor noted evidence of infection at the same tissue level. So then you go back to the intraoperative note and you see that the physician has noted an intra-abdominal abscess, and that's how you know that you have PATOS equals yes. And if you have questions about PATOS, please reach out to us via the NHSN mailbox. So here's our second case. Your patient was admitted for a sigmoid resection, and during the procedure, the surgeon documented within the intraoperative note abscess material in various pockets throughout the abdomen. 5 days post-op, the patient has a sudden onset of nausea, vomiting, and abdominal pain. A CD of the abdomen revealed multiple fluid collections within the intra-abdominal space. On post-op day 6, a CT-guided drainage was performed. 150 cc's of purulent material was drained from the abdomen. This case meets criteria for an organ space IAB SSI. Does this patient meet criteria for PATOS? As soon as the poll opens, you can record your answers. There you go. Okay, I'll give you a couple more seconds, then I'm going to close the poll. Okay, so most of you got that right. The answer is PATOS equals yes. Next question. Because this SSI event meets PATOS, the facility would not report the colo procedure or subsequent SSI event to NHSN. Is that true or false? Okay, I'm going to close the poll. Excellent. The answer is false. So what's the rationale? PATOS equals yes because the patient developed an organ space SSI and an abscess was noted at the organ space level in the intraoperative note. Remember, your subsequent SSI must be at the same level as the documented evidence of infection intraoperatively in order to meet PATOS criteria. And why do you report this event to NHSN? Even though PATOS equals yes, these events are still required to be reported into the NHSN application, even though we don't forward them to CMS. So now let's discuss completing the denominator for procedure information form. The collection period for your denominator data is 1 month. So for example, if you're following an operative procedure such as colo, you would report all the colo procedures that performed at your facility during that month, and you would fill out a separate denominator for procedure form for each colo procedure. As Jim was talking about deadlines, our goal is for you to submit all of your data in a timely fashion, which means ideally you would submit all of your data within 1 month of the end of the surveillance period. But really, we're more concerned with you getting all of your data in before the CMS deadline and making sure that you get it in accurately, because as Jim mentioned, you can amend your data after the deadline, but those amendments will not be sent to CMS. So make sure it's in timely and accurately. I'd like to highlight a few of the denominator for reporting instructions. The first one we're going to talk about is denominator reporting instruction number 4, duration of the procedure when more than one category of NHSN operative procedure is performed through the same incision. So if procedures in more than one NHSN operative procedure category are done through the same incision during the same trip to the OR, you would create a record for procedure that you're for each procedure that you're monitoring in the monthly reporting plan, and you would use the total time for the duration for each record. So for example, if your patient has a hysterectomy procedure and a colo procedure done at the same time, you would report a separate denominator form for each procedure, and you would use the total time on both forms. So this total time from procedure chart time to procedure finish time in the example is 3 hours and 30 minutes. So you would use that duration on the hysterectomy form and on the denominator or the colo form, and you don't want to split that time. The next reporting instruction is denominator reporting instruction number 9. More than one operative procedure performed through the same incision within 24 hours, also known as the 24-hour rule. This reporting instruction states that if a patient goes to the operating room more than once during the same admission and another procedure is performed through the same incision, and if the start time of the second procedure is within 24 hours of the finish time of the original operative procedure, you only report one denominator procedure form for the original procedure. And you combine the duration for both procedures based on the procedure start time and finish times for both procedures. So for example, if your patient has a colo surgery performed on Tuesday morning and the duration was 3 hours and 10 minutes, and then on Tuesday evening, he returned to the OR for an X-lap to control a bleed, and the duration for the second procedure was 1 hour and 10 minutes, you will report one denominator procedure form for the colon procedure, and you would combine the durations and report a duration of 4 hours and 20 minutes, and you would not report the X-lap procedure. The reason we have this reporting instruction is that the concept of a quick return to the OR like that is generally because of a complication related to the original procedure, and we want to roll that risk up into that original procedure. And please note that this rule applies even if the second procedure is a non-NHSN operative procedure. However, if the second operative procedure is done through the same incision more than 24 hours later, you will report both procedures separately. Further instructions related to this: if your wound class has changed, you're going to report the higher wound class, and if the ASA has changed, you're going to report the higher ASA class. And if the patient returns to the OR within 24 hours of the end of the first procedure, you're going to report the wound closure method that was recorded at the end of the first procedure. Next denominator reporting instruction is instruction number 8, the same NHSN operative procedure via separate incisions. So for operative procedures that can be performed via separate incisions during the same trip to the operating room, a separate denominator procedure form is completed for each procedure. So for example, if your patient went to the OR and had bilateral breast procedures, you would report 2 denominator procedure forms, one for the right breast, one for the left breast. And often in bilateral procedures, they'll note how much time was spent on each side. So you would report those separately, but if they don't report them separately, take the total duration of the operative procedure and split it evenly between the 2 procedures. We've touched on ICD-10, PCS, and CPT codes a bit already, but I'm going to talk about them a little more in depth now. As you can see on the denominator procedure form, entering the procedure code remains an optional field. However, as you recall, the first part of the definition of an NHSN operative procedure is a procedure that is included in the ICD-10 PCS or CPT NHSN operative procedure code mapping. As many of you know, every operative procedure that's performed will be assigned a procedure code by your coding department. The procedures that are eligible for SSI surveillance are identified by their assigned ICD-10 and CPT codes, and only procedures with codes that map to one of the 39 NHSN operative procedure categories are included in SSI surveillance. So if your procedure code doesn't map, you can't apply SSI definitions to that procedure. And remember, the mapping documents for your NHSN operative procedure codes for both the ICD-10 PCS codes and the CPT codes are located in the SSI section of the NHSN website under supporting materials. And we update these ICD-10, PCS, and CPT codes at least annually, and it's extremely important to remember or ensure that you're using the most up-to-date set of codes. And as I mentioned earlier, we have both sets of codes up there right now so you can finish up your 2017 procedures. So it's especially important right now to make sure you're selecting the correct code documents when you're doing your surveillance. And also remember that procedures that don't map to an NHSN operative procedure category cannot have SSIs attributed to them. For NHSN surveillance, an SSI event can only be attributed to procedures mapped to one of the 39 NHSN operative procedure categories. This is an example of the first page of the documents. They contain an instructions page, an all codes page, which is the next page here, where all of the ICD-10 or CPT codes for all of the categories, operative procedure categories, are listed. And then each code, each operative procedure category has its own tab with its associated codes. So there's various ways you can search for your codes. You can either go to the All Codes tab or you can go to the individual procedure code tabs. It's very important to note that for ICD-10 PCS codes, they do not contain the letter O or the letter I. They only use zeros and ones. So if you try to enter a code and you get a pop-up that says we couldn't find what you were looking for, make sure that you've entered ones and zeros and not I's and O's. This is a screenshot of the COLO tab in the 2018 ICD-10 PCS document. Under the first column is the operative procedure code, and this is the way all the pages look. The operative procedure category is in the first column, and this one is COLO. The next column lists all of the ICD-10 PCS codes that are mapped into the COLO category. And the next column gives a short description of the procedure. And new for 2018, we've added a fourth column which we've called code status, which will let you know if the code was added this year, if it's no change, if it was here last year and it's here this year, and also if we've moved a code from one category to another. So if you're looking for a code that you used to think was in one category, it may have been moved to another category based on recommendations from our coding experts. So when you're entering a code into the NHSN application, if the procedure code is entered into the ICD-10 or the CPT field first, it will autofill the NHSN procedure code field. So for example, we entered 0DBE0ZZ, and then the NHSN procedure code field autofilled with colon surgery, since that's a procedure code that's mapped to the colon category. If you fill in the procedure code name field first, you can also manually enter your ICD-10 or CPT code. Remember, the procedure code field is required, but the code field is, or the ICD-10 and CPT code field is not a required field for entering your SSI procedure data. In this example, the NHSN procedure code HIST was entered first, and then the user entered the CPT code of 58573. This was accepted with an out on alert because the CPT code 58573 is one of the codes that's mapped to the HIST category on the CPT coding document. This is another way you can confirm that your codes are mapping to the category you think they're mapping to. The NHSN application has some business rules in place to detect entry of incorrect procedure codes. So in this example, the ICD-10 PCS code 0D1HOZL was entered into the ICD-10 PCS code field first. As soon as this code was entered, it disappeared, and the alert was displayed that says that that code did not map. So that is a valid colo code, but we entered an O instead of a 0. So if you get this alert, make sure that, once again, you're entering ones and zeros and not I's and O's. And in this example, the selected procedure code for small bowel was entered, and then a code of 0D770ZZ was entered. As soon as that code was entered, they got the pop-up that this was not a small bowel procedure code, and it tells you what category this actually maps to. And this is another way you can confirm if your procedure codes are mapping to the correct categories. So now we'll move on to some of the required denominator fields. The first field is wound class. Wound class is an assessment of the likelihood and degree of contamination of a surgical wound at the time of the operation. And it should be assigned by a person directly involved in performing in the operation. Rarely should the IPs be assigning these codes. I would say that we'll probably receive at least one email a week asking for NHSN to make a determination on wound class. And that's not appropriate for us to do so because we were not present in the OR, and so we are not able to assign that wound class. It really should be assigned by a member of the surgical team. I also want to point out that the NHSN wound classification system and the protocol is an adaptation of the American College of Surgeons wound classification system. There are other acceptable wound classification systems out there, so you want to make sure that you know which wound classification system your facility is applying. And what we really stress is that your facility is applying their wound classification system consistently to these surgeries. The only recommendation that NHSN does make regarding wound classes is that certain procedures, such as API, BILI, colo, REC, small bowel, and VHIS, cannot be entered as clean procedures. And this is based on recommendations from expert consultants in the surgical field. I also want to mention that C-sex histories and overeat procedures can be a clean wound class based on the particular events and findings of that individual case. We do get that question, and they can be entered as clean. And once again, just want to remind you that wound class should be assigned by someone who's part of the surgical team based on the findings of each specific case. And if you have questions about the wound class that was assigned by the OR, work with your OR to make sure that you're all on the same page, and if something does need to be changed, that they make that amendment to the record. Trauma is another required field on the denominator procedure form. So an example of a trauma is or a procedure that meets for trauma equals yes is if a patient falls down the stairs and fractures the hip and then goes to the OR to repair that fracture, this would be considered immediate trauma, and trauma would be selected as yes on your denominator field. For 2018, we've amended the definition for complex trauma cases where patients go back for repeat operations or stage procedures related to the initial trauma. So for each of those repeat operations that are related to that initial trauma, your trauma would equal yes. If you have a procedure that was related to a remote trauma, trauma would equal no on that denominator procedure form because it's not an immediate trauma. An emergency procedure is defined as a procedure that is documented per your facility's protocol to be an emergency or urgent procedure. And this information can be usually found on the anesthesiology form or in the OR record. Next, we're going to talk about closure technique. So our definitions of primary closure and closure other than primary did not change for 2018. Primary closure is defined as closure of the skin level during the original surgery, regardless of the presence of wicks, wires, drains, or other devices or objects extruding through the incision. If any portion of the incision is closed at the skin level by any manner, the surgery is designated as primarily closed. And this is illustrated in the first 3 incisions. Non-primary closure is defined as closure of the surgical wound in a way which leaves the skin level completely open following the surgery. In this closure method, the deep tissue layers may be closed with the skin left open, or both the deep and superficial layers can be left open. And that's illustrated in the last 2 incisions. So I just want to note that retention sutures can be used on both primary and non-primary closures. And starting with a new rebaseline in 2015, we now send all procedures regardless of closure method to CMS. I want to quickly address packing and wound vacs. So sometimes you have wounds that are described as packed with gauze or other material, or they may have wound vacs or other plastic covering over them. Packing and wound vacs don't necessarily mean that the wound is not primarily closed, because if that incision is closed at any point along the skin incision, it can still be considered primarily closed even with the packing and the wound vac. So you need to look at if there was any skin closure before you make that determination. So now for case 3. A 48-year-old male undergoes a colostomy takedown procedure. The patient has multiple trocar sites, all closed primarily, and a low midline incision that was left open and packed. Is this procedure primarily closed, yes or no? And somehow my polling is not working. Oh, there we go. Okay, I'm going to close the poll. Those numbers are not right. I'm wondering if some of your clickers are not registering. The answer to this is yes. And the rationale is that the skin is closed at some points along the incision. If you recall, the trocar sites were closed, so you've got some of your incisions closed at the skin level, so this makes the entire procedure primarily closed. So the next required field is scope, and I'm short on time, so I'm going to have to speed it up here a little bit. You're going to check yes for this if the operative procedure was a laparoscopic procedure performed using a laparoscopic or robotic assist method. Otherwise, you're going to select no. In the case of a CBGB, where you have a donor vessel from the leg, if that was done using a scope, we want you to select scope equals yes, because this lets us know that you use a scope for the vein harvesting. The ICD-10 PCS codes can be helpful in answering the scope question. The fifth character indicates the approach used in the operation. So if your value is 0, it's an open approach. And if your value is 4 or F, then it is a scope approach. And if your procedure is coded as both scope and open and scope, then you want to record it as an open procedure because this designates the higher risk level. When you're entering your scope codes into NHSN, or you're entering your ICD-10 PCS scope or codes into NHSN, it will autofill the scope field. So if you have a 4 there, it's going to autofill as scope equals yes. And if there's a 0, it's going to autofill as scope equals no. But you can modify this field if you need to. The scope field is not set. So if you put the code in and it's wrong, then you can modify it to yes or no, depending upon the details of the case. So now I'd like to discuss some additional fields that are required for some specific procedures that we have in NHSN. We have 4 procedures for which additional risk factors are collected. Cesarean sections, spinal fusions, H-pros and K-pros. So if any of these are included in your monthly reporting plan, there are additional fields that are required for reporting. If you have a C-sec procedure, you're going to enter the number of hours a patient labored in the hospital from beginning of active labor to delivery of the infant expressed in hours. And you can usually find this documentation in somewhere in your labor record or your maternal records. If your patient is admitted for a scheduled C-section and has not yet gone into labor, then your duration of labor is going to be 0. And if you have a duration of labor that is less than 30 minutes, you're going to round down with the hour, and if it's more than 30 minutes, you're going to round up. So say your labor was 5 hours and 15 minutes, you're going to round down to 5 hours. 5 hours and 45 minutes, you'd round up to 6 hours. Spinal level and approach are required for fusion. We do have ICD-10 PCS guidance for that, and the document is located under the supporting materials on the NHSN SSI webpage. CPT codes don't have that level of detail, so we don't have guidance regarding that from CPT codes. And if you have more than one spinal level that was fused, select the spinal level where the majority of the vertebrae were fused. Finally, for H-Pro and K-Pro procedures, the required fields are whether it was a total or a partial, and whether it was primary or revision. These fields are required, and you also are required to enter if the revision was related to or associated with a prior infection of the index joint. And we do have ICD-10 PCS coding documents that can guide you based on codes to make determinations for these answers. And you'll see that ICD-10 PCS supplemental procedure code, that's not a required field, but you can indicate that if you choose to do so. And I talked about this already. So we're partway down the road of our long journey of SSI surveillance. So now we'll be taking about a 15-minute break. And then Vicki will come up and present the rest of the information. So remember to hold your questions till the end. We'll give you some time after Vicki speaks to answer those, but if you do have some questions right now, we'll be available during the break to answer them. Thank you.